This is effusive constrictive pericarditis. In this apical four-chamber view, you can see paradoxical motion of interventricular septum. This is interventricular septum, and you can see the paradoxical motion. So this paradoxical motion of interventricular septum will give you a suspicion of having some sort of disorder, either left venous block or constrictive pericarditis. But this patient has swelling of legs, little bit shortness of breath, and history of cough and fever. So the likely scenario is effusive constrictive pericarditis. Next image, you see again the same thing, paradoxical motion of. This is paradoxical motion of interventricular septum. You can see here the paradoxical motion of interventricular septum. Again, same thing, paradoxical motion of interventricular septum. You can see here what you see. The IVC, inferior vena cava, is dilated. At the same time, it does not show significant respiratory variation. That is, size does not vary much with the different phase of respiration, indicating raised right atrial pressure. Again, see paradoxical motion. This is subcostal view. We just localize this image. You see, this is parietal pericardium, this is visceral pericardium, and very minimal effusion in between these two. So you can easily say the pericardium is thickened. Let's see, this is size of parietal pericardium. This is size of visceral pericardium. So pericardium is significantly thickened. IVS has got paradoxical motion. IVS is dilated with less respiratory variation. So cases likely to have constrictive pericarditis. Little bit pericardial effusion there. So effusive constrictive pericarditis. Well, effusion is very minimal. You can see this is very minimal effusion. This is very minimal effusion. You can see. So whenever you see the both pericardium thickened, parietal and visceral, minimal fluid between these two structures, and then you find paradoxical motion of IVS, dilated IVC with reduced respiratory variation. The same time, anomalous paradoxical motion. Now I want to show anomalous paradox. You see this in this image. The medial annulus has, this is medial annulus, the velocity is 11.5 centimeter per second. You see here. This is medial annulus, 11.5. You can see cursor at the medial annulus of mitral valve. And in this image, you see the cursor is on the lateral annulus of mitral valve, and the velocity is less. So whenever you see the medial annulus has more velocity compared to lateral annulus, then it is in the favor of constrictive pericarditis. Normal case, the lateral has more velocity compared to medial, but in case of constrictive pericarditis, the medial has got more velocity compared to lateral one, and that is called annulus paradoxus motion. So in this patient, you get annulus paradoxical motion. So medial annulus has more velocity compared to lateral annulus. You can see this image. This is medial annulus, 11.5. This is lateral annulus, 9.86. So ultimately, this is annulus paradoxus motion. So in favor of constrictive pericarditis. You can see clearly. This is the visceral pericardium, parietal pericardium, minimal fluid in between these two pericardium. So this is effusive constrictive pericarditis. So that is the point to know in this case. The image is very hard to get in this case because we have taken subcostal view. At the same time, I have decreased the depth of the image so that the resolution is better. And now you can see clearly this is how image looks. This is image. This is. You can see both pericardium thickened, very minimal fluid in between those. Just if you want to measure in this case, then measurement will be very less. You see, almost very less. 1.4 millimeter. That is very less. So ultimately, this is the case of effusive constrictive pericarditis. Points to know, points we came to know from this video is annulus paradoxus motion. Medial annulus has more velocity compared to lateral annulus. That is annulus paradoxus motion. Second thing, paradoxical motion of interventricular septum. Third thing, IVC dilated with decreased respiratory variation. One thing is here, this is the fourth thing that you can know from this image, though this is not video. Video is not moving. But in this image, what we have seen, the diastolic flow reversal in mid-hepatic vein has got more expiratory diastolic flow reversal. So diastolic flow reversal is more at the beginning of expiration. So expiratory diastolic flow reversal in hepatic vein is in favor of constrictive pericarditis, but inspiratory diastolic flow reversal is the finding. Whenever you see that finding, then that will favor of, that is in the favor of restrictive cardiomyopathy. So that is the point to know. You will find in this case expiratory diastolic flow reversal in left liver mid hepatic vein, that is seen at the beginning of expiration. That is the point to know. So whenever expression begins, just see here, this is the part where you the maximum diastolic flow reversal. This is reversal flow is above the line, baseline, and normal flow is below the baseline. Because in this image you just see hepatic vein drains into IVC, so the normal flow is downwards below the baseline. Reversal is above the baseline. This is the flow that is above the baseline that you see in this image. Above the baseline, this is the above the baseline. That is reversal flow. That is diastolic flow reversal is seen during the beginning of expiration. That is in favor of constrictive pericarditis. And this point helps you to make difference from restrictive cardiomyopathy. Thank you.